Welcome back to the Advancing Healthcare Innovation Show. I am your host, Michael Stamatinos. And if you're new to us, man, we're super excited to have you here. And you know why? Because we're bringing very exciting conversations with some prolific leaders in our healthcare industry that are painstakingly shaping the future of our industry. And we happen to be really passionate around innovation, adoption, leadership, and access. And if it's your first time tuning in, let me just sort of take a quick step back and let you know a little bit more about what we're trying to do here. So we are a healthcare innovation company, and our focus is bringing real stories of leaders within our space to life. And the aim is letting them have the space to sort of share some of the things that they've been working on, the good, the bad, some of the learnings. And it's just really fun to be able to do that and listen in. And if you haven't checked out any of our historical interviews before, make sure you hit the subscribe button now so that any of the new interviews come right to your inbox. And if you haven't checked out any of the historical interviews, make sure you spend some time there as well. And as part of our commitment to just keeping you updated with the latest advancements and solutions within healthcare, we've got a really innovative leader today who's pushing the boundaries and shaking things up. And I'm pleased to introduce Dr. Craig Beavers. Dr. Beavers is the Vice President of Professional Services at Baptist Health System, Tucking, Indiana, where he leads the cardiovascular, pharmacy, and surgery departments. So he started off as a cardiovascular pharmacy specialist at UK Healthcare, which fueled his passion for cardiovascular health. He's still a clinician, still sees patients today. And Dr. Beavers' work is not only just valued locally, but really all across the US. And he was chosen to be the chair of the American College of Cardiovascular, American College of Cardiology Cardiovascular Team Section. And he's also a fellow of the American Heart Association and an associate of the American College of Cardiology. Quite impressively, Dr. Beavers was also the first pharmacist to be recognized as a cardiovascular professional by the Society for Cardiovascular Angiography and Interventions. So throughout his career, Dr. Beavers, and he's really shared his knowledge extensively. So I'm very, very excited digging into this conversation. So whether it's been writing papers, abstracts, and even textbook chapters, and even having spoken internationally, he's done quite a bit for the field. So Dr. Beavers, it's really impressive that you're on here. We're appreciative and thrilled to have you with us today.
Thank you for inviting me. I'm excited to talk about how we can continue to really try to come up with creative solutions to solve the complex landscape of healthcare to get our patients what they need to be managed in the best possible light. So
I think you're a really interesting combination of clinician, administrator. So when you look at when you're looking at challenges, how do you typically view it from? Do you have like a default mechanism as viewing it from as a clinician? Can you maybe kind of talk us through that lens of things?
I think that's interesting. If you really look at my trajectory, and as you alluded, I'm a cardiovascular pharmacist, and that's my root and love and passion is I started out as a pharmacist. I did especially training work in cardiovascular disease because that was my interest, but then through my through my clinical professional career, and have always been interested in research, I got engaged in a lot of different solutions. And I think part of that is the way pharmacists are trained to look at things both clinically and operationally, because pharmacy is one of those unique areas where we are embedded in the clinical space, but are still tied to an operational component, i.e. that's drug and drug delivery. If we think about, yes, we know what drug and drug therapy needs to be provided to a patient, but the process of how does that get there, whether that be out in the community, whether that be within the own institutional hospital walls, pharmacists have to work across all different teams and aspects to help make that process work, because there are either limitations to where they can be given, how they're given, or et cetera. And so you have to have a little bit of ability to speak both language sets, both a clinician-based language set and an administrator-based language set, to be able to address them. So then when it comes to working through other issues, whether it be quality improvement or other avenues, and just the meticulous nature that pharmacists think through things, it becomes a natural fit for developing novel solutions across the board, because we're seeing things, in different silos or other areas that other people may not be seeing them, or appreciate the pain points that both sides are dealing with, or even the patient is dealing with from that standpoint. So I think when I look at solutions, I really look at it through a pharmacist lens, and that's where I go to, and that's where I always think about, okay, in the real sense, and in most healthcare environments, drug therapy is going to touch a patient. And whether you agree or disagree with that, how that should be the case, or what that means for us as society, there always is going to be a drug therapy component to that process. And so I start from there and kind of work backwards, if you will. So
That's a really interesting way of looking at the world. When you transitioned initially from full-time clinical practice, excuse me, to administration, how important was it for you to continue to have a percentage of your day or work schedule to be treating? And was
no,
that
I think it's very important. I'm a big believer of always having that ability and perspective, because I think you still get appreciation of the challenges and the problems, and it's really something I've taken to heart in a lot of light. So even when I was working full time as a clinical pharmacist in a hospital based environment, which I still am doing that, but doing clinic work, I was still also picking up shifts and working out in our community pharmacy environment, because I was like, our patients, when they get discharged to the hospital, that's their next touch point, right? So I wanted to understand, what are they experiencing after they leave my walls, right? And what does that environment look like? So I would still engross myself in that environment, so I understood, okay, what are my peers dealing with? What is the patient seeing when they leave? So then I could make better decisions for the patient on my end in my daily life, because I'm like, well, having just been there recently, I know that the patient could encounter this, or here's where I can see that the system has failed them, so I'm not going to let this mistake occur again, or know that this could be a trap. So to me, it's very important to have different perspectives, and realistically, if you aren't able to get that perspective or don't have a perspective, it's important to always talk to other people who are in that area to get that perspective. If you can't get that perspective yourself, I mean, it's funny, and I do a lot of work in other organizations about diversity, equity, and inclusion, and I argue that part of that is also understanding the diversity of environments and people's backgrounds and skill sets as a part of that conversation, because we all have different experiences there too. And if you haven't been a part of a system or an area or an environment, or even a setting, so like if you've only worked in an urban-based environment, and you have patients that may be transversing to a rural area, you have to appreciate that perspective, because they're totally different barriers and challenges. And so I think it is important to understand that the world is complex, and the only way to break down that complexity is to be willing to accept that you either need to appreciate that and engross yourself in that diversity, or you need to have conversations with people who are doing it, and be willing to listen to what their challenges are to remove those barriers.
So there's been a lot of talk around challenges that leaders face, operators are facing, kind of coming into this role. How do you view the noise versus what problems you can actually tackle? How do you prioritize problems? And have you noticed that there are certain emerging themes, and what has your intention going into the new year?
Yeah. So, I mean, my current, clinical practice is primarily tied around heart failure, and heart failure as a disease state entity. And I think heart failure is a great disease state to be working with or working through for a variety of different reasons. And a lot of things that are tied to heart failure can be tackled or related to other disease states. So heart failure, if you're not aware from it, it's a syndrome where your heart does not deliver enough oxygen to the body, caused by a variety of different factors. Very much treatable in the sense that there's lots of things that we can do to help manage those patients. Very much a lot of interest in heart failure at this time because of that. And a lot of times it's a chronic disease state. However, because of all these things, it also underscores a lot of the challenges that exist in our current healthcare environment, whether that be, a lot of times patients have to be on what we call guideline-directed medical therapy, which includes several medications that are very successful at treating patients. However, that, underscores a lot of things like polypharmacy, the need for patients to be able to afford therapy. It undermines adherence issues. It really brings to light social determinants of health and all the challenges that we face every day, and that have really come into the conversation around managing patients from that standpoint. And then it just talks about, undermines the process of care complexity, and there's a lot of readmissions that occur with heart failure when it's not managed appropriately, a lot of cost tied to the disease state. There's lots of holes that can exist in the Swiss cheese model of healthcare with heart failure patients. And so it really is a good disease state to work through and really identify problems, because you may underscore, to your point, very common themes. And of course, there may be noise there, but you see themes that are very germane to other disease states and entities that if you work through them with heart failure, you're like, well, this worked in this population to some degree, and how do we tie it into that entity, or vice versa? So, when I look at things, I look at what are the reasons that my patients are not, excuse me, are not able to garner the success like we're supposed to see. And of course, I'm a big believer in multidisciplinary teams, including pharmacists to be a part of that team due to their unique skill set. But I look at it, okay, we know what we need to do. We know data suggests these things need to occur, but why are they not occurring? And that's where we kind of look at the construct, and you alluded to, of implementation science. And that's
so maybe we take that use case that you just kind of drew up and talk about how you're leveraging implementation science to be really proactive across this particular problem set.
Yeah, and so looking across the chasm of translational science and what we do and know, a lot of my interest and focus on is really taking that late stage. We already have data that suggests something is very effective in either reducing mortality or readmissions, et cetera. But then we know there's data that shows that evidence uptake is hard. It takes usually 10 years for stuff that we know works to come into practice. What are the barriers to that, and why do we have these barriers? Or if we know a patient population or subgroup of population is not receiving treatments that they need to receive, why is that the case? And knowing that there are different barriers and things that are tied to that, the goal of what we do with implementation science is not necessarily to study what reduces mortality, but to say, okay, how do we take something that we know that works and understand why is it not being put into practice or being used, and then we test out interventions to make that not be the case, or there not to be barriers there. And then so you test the intervention and retest the intervention until you get to something that your study that you're studying is, does this improve the uptake of this medication, or do we remove that barrier? Or if, for example, the barrier is patients can't, and this is just a hypothetical example, patients can't remember to always take their medications or get them filled. Do we provide them a device and we test that device over and over again until we get to the point that they know this is the process and the device and how it works the best for them to use that, and then that increases the uptake? Or the reason prescribers will not prescribe something is because they are not clear that this is the way what are the drug interactions, or there's some barrier there. We just test that intervention over and over again until we capitalize on what works best. And then knowing that once you do that, you will improve the outcome. So you're not testing, oh, we know it reduces mortality. We don't need to test that. We need to test what is something that will increase the uptake, or alternatively deter people from doing practices that are not good, right? Like, so if we know there's a practice that is of detriment, how do we create interventions that deter that practice from that standpoint? And that's kind of a basic foundation or concept of what we do with implementation science, is really figuring out what are the things and the challenges. And there's lots of ways this can be applied to, and caveats that it can be put towards, but that's really the goal and aim, is to really, okay, this is how we can do this more efficiently or more quickly. And then of course, the alternative is, can you do it in a process that doesn't cost a ton of money, right? Or how, how resource intensive does this have to be, right? Because you may come up with a very good intervention, but if it's going to be super resource intensive or cost a lot of money, that may not be the best intervention. So you have to say, how can I do this in a more scalable fashion, right?
Are there any examples that come to mind that you can share?
Yeah, I mean, I think, for example, one of the things that I've worked with or looked at is, and this isn't necessarily in the heart failure population, but just knowing there's a lot of disparities of care in terms of giving patients with HIV who have had atherosclerotic cardiovascular disease, or, a lot of them do not get statin therapy and would benefit from it because it's a highly inflammatory disease state. And part of that problem is, historically there have been lots of drug interactions and barriers to those two therapies, and a lot of that has evolved and changed over time. And I don't think people who are not practicing or managing HIV patients, or patients living with HIV regularly, they may not appreciate that. And so it's like, how do we devise educational interventions to remove those barriers to the people that are prescribing, so they have a better appreciation, or teach them at the time of ordering, when they have a patient with HIV, that this is okay, and just using the tools. And I laugh because you talked about noise earlier. Sometimes things that seem to work very well, like what people think would be alerts and interventions, those actually become noise to people, unfortunately. And so you have to think, okay, what are interventions that people are going to pay attention to? And kind of put that in there. And it can be a mix of things: education, direct intervention, those things. So, but that's an example where we've used kind of information and surveying of clinicians to understand, why is it that, we give them scenarios and cases, and then take the ones who aren't doing it and say, okay, when you did this scenario, you did not give this patient this therapy, and they would be indicated. Why would you? What is your hesitancy in a real world setting to do this? And then, so you take that feedback and then devise an intervention, and part of it's education and the process, or how do you quickly help them identify, these are the therapies that are okay to be given this therapy from that standpoint. So that's kind of what you do, and then you go back and forth, and you just.
But how long is the experiment that you run? How long do you run the experiment?
So generally, when you can, it depends, and I don't want to say that everything is the same, but I mean, for this type of part, is really once you do the qualitative part, where you're talking to them and trying to understand, that's an experiment in its own right. So okay, and that one's relatively easy, because you're just doing scenarios with people to understand what their gaps are, and then when you determine the people that have the gaps, why do you have these gaps? And that's the scenario, that's the test. Okay, and then here's what we've input, and then you create the intervention out of it. And then once you devise the intervention and test it, that can take, usually they're a little bit more efficient than, you say, a randomized controlled trial, because you already have identified the population, and the intervention that you're using, you're testing over and over again. So that's your sample. So it can take a year, a couple of years to get that data, sometimes more efficient depending on how many times that data point or whatever you're looking at fires. But it takes a year or so or more to test out an intervention like that and get high quality, reliable, consistent data. So
and do you find
it's a part of a process, though, right?
Yeah.
So
And with respect to other issues and other challenges that come up, you mentioned social determinants, and I'm just reminded of that story that you shared about, meeting patients where they're at on their journey. I believe you mentioned it was one of your neighbors. And to talk a little bit about how
Yeah.
you're approaching social determinants and some of the proactive things that you and the team and the health system's
Yeah.
doing.
Yeah. No, I mean, I think, it's always surprising to me. Well, let me rephrase that. Surprising, but not surprising. We, sometimes the things that you or me or everybody takes for granted, and you read stories like X amount of population doesn't have internet in certain age groups and those types of things, and you're like, well, you have a really great intervention. So like a app-based intervention or a telephone-based intervention or something, you're like, oh, this is great. We all have these devices, or we all have access to a computer, or we can have access to the internet and put something in there that helps the patient remember to do these things. And we're like, oh, this will revolutionize things. And then you're always humbled to find out that even in a city landscape area, you find out, for example, I found out my neighbor, my next door neighbor, an elderly couple, they have no internet. In fact, they were asked to do a virtual doctor's appointment, a telehealth visit, and they ended up contacting myself and my family, my wife, to ask if we had the internet and they could come over and do that. And you're always like, and these are like some of the people you're trying to target, and you're always humbled to find that couldn't exist where I'm at or where I'm living. But then you find out, it's your next door neighbor actually is the person that you're thinking about in these articles, or you read about in these articles, and you're like, and so then you begin thinking, okay, so how do I reach them, right? And that's the question is like, okay, how do I, if I have a patient that I need to intervene on, how do I create something that may not involve technology but is effective for them? And likewise, I had another patient in our heart failure clinic who had, obviously heart failure and polypharmacy, and I was asked to look at their home medications and clean them up, and I asked them to bring their their pillbox in, and so a simple intervention that you think would be helpful about adherence and a tool, and I opened it and started working through it, and it had all sorts of things in the wrong place, and doubling of meds, and just things that shouldn't have been taken together because of risk of adverse events. And the couple, they were also an elderly aged couple, and unfortunately had no access to family to help them. It was just the husband and the wife, and they couldn't get to a pharmacy that could pill pack things for them. And unfortunately, the insurance company was just sending them things. So it was just creating a recipe of disaster. And so, we tried to use a prospect where we have them, because they can do this. And this is where you have to be a little bit, have an intervention that is centralized, but then tailored a little bit to the person that's there. We have them coming on a regular basis to see us because we're going to become their support system to some extent, and we're going to fill their things a week at a time, make sure that they're getting the right things, and owning them through this journey, and then providing some check-ins from that standpoint. And that's a little bit, it sounds resource intensive, and it is intense in the sense that we're following them, but we're working them into their normal parts of their visits and their flow. And while that doesn't seem groundbreaking, it is, because it is providing them the care and attention that they've not been able to get under their current circumstances, just where they're at. And so for them, it is innovative, right? And that's the way I look at it, is like, sometimes the stuff that you do not think is innovative, from the patient's perspective, that is innovative for them, right? Like, they think that is innovative technology or process, what you're providing to them, because it's us as a pharmacist that they've never probably interacted with before, that are doing something to them and providing them a service and keeping them safe, that that they did not appreciate or suspect any for. And arguably someone could say that's just service, and you could say that in the case, but it's how that service is delivered, and it being a multidisciplinary process, and that we're focusing on this for that specific disease state, that's innovative to them from that perspective. So I think it's, it's a part of that, and that's just one construct. Of course, we're doing other innovative things too, but even sometimes you have to step back and say, okay, what is innovative to this person that would be helpful to them? You know what I mean? So
Yes. Yeah, getting back to true north, which is
right.
What are you trying to do? You're trying to help the community, and what is the community comprised of, and where are they on their journey, and what may be innovative to you? Maybe it is an app because you're not necessarily tech savvy, rather you're tech dependent. That's different from someone who doesn't necessarily use technology, and maybe they think that a reminder phone call from someone that is from a clinic or facility checking up on them, that might be innovative to them because it seems as though that they care. And you're right.
Yeah.
Maybe it's perceived as good service.
But
the eye of the beholder thinks that it's innovative.
Right. And that's where I always try to have a conversation with our patients. Like, what are we, where can we meet? I guess it's a part of the shared decision-making process, if you will. Okay, like, what are your goals and how are we going to get there? And what are the ways that we can help do them? Now, obviously, like I was alluding at the beginning of this call, you want to find things that are scalable and unique and helpful. And there's a multitude of those things that are out there. And kind of what you're saying, what is noise and what is not noise? And I think we're getting better at defining what is helpful and useful. I will tell you, though, some things that are very innovative, they make sense and they would be perfect to use or could be useful, but then if the patient doesn't use them, they really are not. And I think, sometimes, for example, some monitoring platforms, they're very innovative, could be a great asset to managing patients, but the uptake of patients is not good. And then they become useless in a sense if they're not going to use them. And so that's part of that. How do you remove that barrier of how are we going to get people to use these?
What's acceptable from a utilization standpoint, from your point of view? What is acceptable in terms of making a dent?
I think if you have, I would even argue if I could get 50% of my population to do a certain activity, I'm thrilled with that, because knowing that there are different challenges. Now, I want to understand why the other 50% are not doing it in theory, but even getting 50% or more of my patients to do certain things would be amazing, or i.e. other way around, providers to do things, or et cetera. Just because they're like, why are we not doing this, or why is it that we still are concerned about this X, Y, and Z, or what are the reasons that this is a problem? And then I will tell you, sometimes the barriers are not even within a system. It could be governmentally related, it could be reimbursement related. There's other things that are tied to it. And it's just really trying to understand why we're not doing things and where do we need to make those adjustments.
So let's just say we're having a conversation a year from now, fast forward, and you being a student and a practitioner of implementation science, if we're looking back, what needs to have happened in order for you to feel really satisfied with the progress?
Yeah, I think I think two levels there. Obviously, satisfied being that anything that we're working on, specifically with the populations we're studying, that we show some benefit, and whether that intervention be, for example, working through a large scale grant that we're doing that looks at some medication adherence interventions and using some technology to improve that. But then secondarily, just more people being engaged and curious and learning about implementation science, because I think it's a type of science that is accessible anywhere. And so even if you're not at a large university or have no major research experience, it's something that people can kind of learn about and try to implement and do, and you can really potentially change that process. So I guess my hope is that more people get engaged into the construct or understanding of implementation science.
And where, even if you don't have them available, we could always kind of
Yeah,
drop it in the description.
no,
But where can they follow, particularly your work? Maybe even learn more about implementation
sure.
science, because presumably there'll be folks that want to know more.
Yeah, no, I mean, I will tell you, you can follow myself on X, which used to be Twitter, at Beavers PharmD, and of course I'm on LinkedIn, so that's my last name, Beavrs PharmD. Um, Resources that do implementation science are great places to start from that are doing it very well. Is Indiana University's implementation science program is very strong. Um, you know, our UK, we have a great program embedded in the clinical trials or clinical and translational science program in our College of Medicine. Um, However, there's some great implementation networks, again, also on X. And if you just search implementation science and look at that as a hashtag implant sci, you can find all the people that are working in implementation. And it's interesting, it's not just in healthcare that are looking at implementation science, but the framework and the construct are very similar from that standpoint. And then the NIH has a subsegment of implementation science work that is going on. But it's becoming more in the vernacular. For example, at the American Heart Association, they had several sessions focusing on disease states and how we do implementation science. And, you know, for example, at Cleveland Clinic, they're doing a process with their heart failure patients where they have used their EHR to embed alerts that go to a clinical pharmacy call center. And then depending on those thresholds and when those alerts are fired and so forth, the pharmacist keeps intervening with the clinician to get those things done. And then once they get prescribed, the pharmacist follows them up. So there are people doing very unique and insightful things at that instance. So I think, you know, again, I try to intersect the disease state work that I'm doing and implementing a team-based approach with pharmacists being a part of that. And so that type of stuff is really music to my ears. I obviously, being biased as a pharmacist, I think pharmacists have a huge role to play in the healthcare system. That talking about a somewhat, in theory, innovative resource that is underutilized in my mind. But
Well, it sounds like what you're doing is you're a conductor there, because you have
yeah,
a symphony of different instruments and you're putting them all together, and you're doing it in a construct that allows you to either to experiment and to learn and to
yeah,
continuously get better. And an aspect of, for me, innovation is around, number one, adding value to many and incrementally getting better over longer stretches of time.
yeah.
So you're hitting both of those head on. So it's exciting. Anything else that maybe you want to share with the community, with the audience? Give you a
No,
few
I
moments
mean,
here just to sort of
I
share.
think there's, I think keep, you know, if you're interested, keep the dialogue going and keep, you know, if people want to follow and reach out, happy to connect dots and 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 hear conversations. Again, I'm always open to learning and hearing what other people are doing or connecting people to other people who may be interested in this space. So
Amazing. Well, for those that have tuned in for this conversation today, if you found the conversation with Dr. Beavers and I to be helpful, would you mind sharing it on social media, liking it, commenting it, share some love. It's always nice for us to know how we're doing and to get that level of feedback. And as always, we'll always want more doers in the community. So until next time, see you soon. Thanks, Dr. Beavers.
thank you.